Alright, so the first thing we're going to do is we're going to go ahead and start up Easy Notes. And our goal for this initial training is to go through the DC note, the treatment plan, the exam, and the x-ray report. The subsequent trainings will have to do with new patient. New patient is about, probably over an hour just in itself. There's a tremendous amount of information just with that, just becoming familiar with the screens and all the different ways you can do a different case history. By far the most important thing that we have to do is the DC note. So before we get started with the DC note, I'm just going to replicate using some sort of character. I'm running out of cartoon characters, but maybe I'll do Superman. So the patient's first name is Super. Last name is Man. You'll never need to do this because Easy Notes is essentially a slave to HSWorks. So all the names get entered into HSWorks and then automatically get populated into Easy Notes. So again, DC Note, it's what we all do, it's what we all do all the time. And my goal is, if nothing else, for you to feel comfortable doing a DC Note right now. So the first thing I'm going to do is I'm going to go ahead and hit DC Note. I can type in here if I'm using a laptop or a desktop computer. If I'm using a tablet, a touch screen, I could go up here, but the last name should be Man, and there's our friend Superman. If for some reason I need to backdate this, I can down here. Otherwise I'm just going to select them. Now I get prompted with a whole bunch of things. For the purposes of this, we are going to pretend like Superman has been coming in to see us for years. He's not a new patient, and we actually did an exam last week on him, so there's no reason to do an exam now. It's just that Easy Notes thinks that I haven't yet. Next, it's asking we need a current treatment plan. Again, we probably did one last week when we did the last exam, so there's no reason to do it now. We're just going to say no. The first thing I do once I'm in is I look to the left for current diagnosis and it's empty, and I look to the right for patient problems and it's empty. As soon as I know that, I know, now I need to go through all 18 screens. So it's got to get the data from somewhere, so I might as well just enter it in now. And I'm just going to ask Superman, how are you doing? And perhaps he says slightly better. Maybe he's suffering from neck pain. Wherever I click on these figures, I get different lists. I'm going to click the neck. Maybe he has neck pain and headaches, so I'm going to choose neck, and he says it's a 7. Perhaps and then I'm going to click the head again, and he has tension headaches, and he says they're about a 5 right now. When I'm done with this screen, I'm going to hit done, and there we go. We're done with 2/18 of the screens. Our next screen are things that aggravate and things that make things better. One of the things I've been trying to do for everybody to explain just how great the handwriting recognition is with Microsoft tablets is I'm going to choose a couple things. Maybe it's when he golfs, whatever, and I'm going to hit other. Perhaps he plays hockey. So I'm going to pull up my handwriting recognition, and you're going to see I have horrendous handwriting. And I'm going to write in plays hockey. And as long as you spell things correctly, it does a phenomenal job converting it to text. If you misspell things, it just doesn't work. It tries to find things that it could possibly be. Does not like the word subluxation for whatever reason. I hit accept, turns that into yellow. If I want to unselect it, or I made a mistake anywhere, I just simply select things, unselect them. I ask him what. Absolutely, I can hold.
Yes, sir, what?
I can still hear you. Can you still hear me? Excellent. All right. No problem. Oh, I thought you were talking to me.
No, I was talking.
Oh, okay. That's why I said, yeah, I can still hear you. All right. So Now we have the relievers, what makes things best. And he says, you know what, doc, really the only thing that I can say without a doubt that you're doing is the adjustments. The adjustments are by far the best thing. When we're finished with the screen, we hit done. We next move into the screen. Is he doing his exercises? This means, is he doing his exercises outside of your office? And, you know, being Superman, he probably doesn't lie very much, and he says mostly. Next, we end up with the ranges of motion, and it's all done within category. And we're going to modify the cervical ranges of motion. Cervical ranges of motion are divided into three categories. We have just restricted, restricted with pain, or normal with pain. And we can use any combination we want, but obviously it can't be just restricted or restricted with pain. Maybe when we have, maybe we're just going to ultimately just say left rotation and left lateral flexion. When we're happy with it, we hit done, and the information shows up under the cervical area. Do I want to keep it the same? Absolutely. Next is our palpation and observation screen. There are a lot more options in here, and you can remove some of these options, and we will go over that really briefly. It's very easy to do, but you know, depending on the insurance carriers and things like that, things like hypertonicity, spasms, and visual muscle tightness, as far as I'm concerned, are all basically the same thing. But certain things like colossus are actually looking at, maybe not now, but at one point, we're looking directly for the word spasms, where hypertonicity and visual muscle tightness didn't give you any points when they ran through their scanner. First thing, all of these things, except for things that have to do with vertebral segments, are all going to be the same. So we're just going to go over maybe two of them so that you see the same. Maybe we've got edema. Again, we have the figures, and based upon where we click on the figures, we get different lists. What Easy Notes starts to do from this point on is it starts to help you a little bit. It starts to create things like neck and tension headaches. I'm going to minimize this, unlock the taskbar. Oops, taskbar, not manager. Unlock it. And maybe we'll move it over here, just so you can see the buttons. Ooh, what am I doing? Just so you can see the buttons that are there. Okay, so now we've got this thing over here, and we're going to try and shrink it as much as it lets us shrink it. Apparently that's it. But that way you can see the buttons at the bottom of the screen, since we have it blown up with the highest or lowest definition. We have whatever I have selected in yellow down here tells us what type of category it's going to be when I select things. By default, it's always no quality. And no quality doesn't mean that there's no quality to what it is. What it means is it's just not saying it's mild, moderate, severe, or less. But we're going to say there's mild things over his neck. And what Easy Notes does is it starts to create buttons for you, so you don't have to go to the figures and search for the words based upon the patient's complaints. So we're going to say neck. Maybe tension headaches. Well, I don't know how you would have edema and tension headaches, so maybe you have to choose something else. Maybe the frontalis muscle. When you're happy with it, you hit the button that says done right here. Our next screen, or we're back here, and if I had chosen flaccidity, again I get the same things. I'm just going to hit back. Segmental joint dysfunction. So, but you're the doctor, you're always in charge and able to override anything. However, if you're going to list the vertebral segments that you adjust, those automatically become your segmental joint dysfunction segments. So there's never any conflict between what you're saying was a subluxation and what you're correcting. But being the doctor, you can always go in here and override it. I recommend not doing it unless there are specific subluxations at some point in time you decide that for whatever reason you're not going to adjust. Perhaps there's some capsular swelling that's mild, and it's over C2, C3 on the left, maybe C6, C7 bilaterally, C7, T1 on the right, and maybe T6, T7 bilateral. Maybe there's some visual muscle tightness, and I'm not going to say no quality, so I'm just going to go straight to here. And I don't want to use the word neck again. Instead, I'm just going to say cervical musculature. And I hit done. When I'm happy with this screen and I've gone through all the things I want to do, I simply hit done. Some people perform orthopedic tests as part of every single office visit. If you've ever been really bored and read the small print and you have NCMIC malpractice insurance, one of the things you'll notice is George's test is something you agreed to do before every single treatment. So we'll just pretend like you have an NCMIC and you did that. So we did George's screening procedure and we hit within normal limits. And then we hit done. Next we go to modalities. There are a ton of different modalities that have been turned off. There's probably at least 5 or 6 that have been turned off. But let me just ask you, which modalities do you use in your office?
Laser therapy, muscle stimulation, decompression therapy,
okay.
therapeutic exercises.
Perfect. Well, let's start with laser. We're going to hit edit for laser. Now what it does is, besides just the figures and the one words like neck and tension headaches, it gives me 2 choices for the word neck. I'd either choose the word neck or I could say cervical musculature. I'm going to choose cervical musculature and suboccipital musculature for 8 minutes. If I do decompression, I'm going to go down here where it says special traction, and I'm going to hit edit there. And here are the different special traction tables we have, and perhaps you're using the Chattanooga DTS cervical. And we did it over the C5, C6 disc, and we used 25 pounds of pressure. Now, I'm not sure if that's a lot or not, but we'll pretend like that's normal. You could enter whatever you want. Electric stim, again, just like laser. We get our buttons, we have our figures, we can mix and match as much as we want. So maybe we did some electric stim for whatever reason over the upper thoracic musculature for 10 minutes. Guy was here for a while. But he's Superman. You can make up for his time other ways. Okay, again, just like the other screens, there's a lot more options for all of your adjustment techniques. Last person I did this with, these were the adjustment techniques they use in their office, and they wanted to see how big everything gets. Which adjustment techniques do you use in your office?
Pro adjuster and diversified and drop.
Okay, good. Pro adjuster, diversified, and drop are all basically the same screen. So we're just going to hit diversified. Now we have 2 categories here. One says with X-ray, one says without X-ray. And they're basically the same thing, except with the way all the text is randomized, between 30 and 40% of the time, when you choose from the left-hand side that says with X-ray, part of the verbiage that gets spit out is going to include the words partially based on X-ray analysis. We'll also include motion palpation, static palpation, point tenderness, things like that, but it will, less than half of the time say also X-ray analysis. We're going to pretend like we actually took X-rays on Superman. I don't know that you can, because you think he would be too strong for those beams, but whatever. And what we're left with is the vertebral segments. I wouldn't use regions. You technically can, but if you want your subluxations to identify with the vertebral segments, you've got to put them in there somewhere, so you might as well do it here. Diversified listings, drop listings, are all the exact opposite of Gonstead. And I think it's a much easier thing to think about. It's just this side you adjusted. So if we adjusted C2 on the left, it would be C2XL. It's the high transverse process. C6 on the right would be C6XR. Perhaps we did C2 on the left, and we did T6 straight posterior, we just hit it in the middle. So it's just wherever you adjusted them. Much easier to think about than the opposite and all the crazy the Gonstead things. When we're done with it and we're happy, we hit done. Our next screen that comes up is progressive rehab. We've got, right now at this point, we only have the 1.0 exercises. We don't have the 2.0 exercises in there. We have other exercises and then home exercises to give to a patient. We're going to start with just saying progressive rehab for cervical phase 1, and everything automatically is checked for me. And he's Superman, so we're going to use the high, instead of mild or moderate, we're going to use 10 minutes. And probably would have snapped those things in half. When we're happy with the different cervical exercises we did, we hit done. We didn't do any other exercises or home exercises, and we'll go over those later. We just hit done. After the treatment, Superman said he felt slightly better. You noticed that his cervical range of motion had increased, and the cervical musculature texture has decreased. When you're happy with it, you hit done. You want him to come in again tomorrow, and the only reason I'm choosing this is we're going to do tomorrow's note immediately following this one. And what we have here is we have the prognosis. Automatically it tries to come up with too early to tell because Easy Notes thinks he's a new patient. He's not a new patient. We've been seeing Superman for a long time. So we're going to say it's actually good because he's responded well in the past. When we're happy with it, we hit done. We're on our last screen before the super bill. Did he complete treatment without incident? Yes. If we said no, it would ask what the incident was. And now we're at the super bill. On the super bill, it's pre-selected the different items for us. It pre-selected laser for S8948 for us. It pre-selected therapeutic exercise based upon the ones we did, and attended STEM, and we only did 1 to 2 regions of adjustments. It's also trying to get my attention here for new patient and x-rays because it thinks it's a new patient, but it's not. I've been seeing Superman for years. But what we do need to do is we do need to address here where it says new DX. And we're going to choose cervical. And what we have is we have 2 different lists that we can choose from at any time. We also have keys up here and a search box for us to use at any time too to help narrow down the choices. The things that I select in the center change the list on the left. The list on the right are all of the different diagnoses that are inside here. So I'm going to start off with primary conditions, and perhaps he has, well, let's see, what do we have? Oops, shouldn't have hit that button. Perhaps he has a little bit of torticollis. I highlight it and I hit select. Maybe he has some subluxation, so I'm going to use 739 because I find it easiest to find it that way, and select it. But I also adjusted his thoracic spine, so I'm going to say 739 again, and I'm going to choose thoracic segmental dysfunction. And he also had headaches, so I'm going to choose tension headaches and hit select. When I'm happy with my diagnosis codes, I hit the done button. Now I choose the onset date and I hit the done button. Now I'm back to the super bill. To post all of these charges, again, I'm the doctor, I can override anything here, but when I'm happy with it, I hit send to Funky and the charges automatically go into HS Works. When I hit done, I have my note. And this taskbar thing is, drag it back down here, was covering a lot of stuff, so I'm going to put in here, I'm going to sign on the screen, and I'm going to use my signature with my fantastic handwriting, and hit insert signature, and it puts it in there for me. Now, this takes about, this would take me about 1.5 to 2 minutes. And I'm really fast. I built the whole thing, so I go pretty quickly compared to what most people can expect. With that said, the data's got to come from somewhere. And once you get the data in there, it gets very fast. I would expect the first time somebody tries to do this on their own, it might take them between 5 and 10 minutes. Second time, probably about half. If you do it 10, 15 times, probably going to be about as fast as I am, because the buttons don't move. Especially since you're going to have your own modalities that you use, you're going to have your own exercises that you use, so you're going to just naturally start to look for the buttons that you need. What we're going to do next is now we're going to get to see where the beauty of all of this comes in. We're going to say today is now tomorrow, and our friend Superman comes back in. Again, it's reminding me that I need to do an exam. I've done the current exam, so I can ignore it. I'm still the doctor. First thing I notice is we have diagnosis codes on the left and problems on the right. That tells me immediately visit summary. Now I only change what's different. And the reality is, what's different from visit to visit? You know, maybe some palpation and observation things go down. Maybe the patient problems go down, but typically I'm going to do the same modalities, the same adjustments, and the same type of rehab visit to visit. So we're going to modify the problems a little bit here. Maybe he says his neck is now a 6, his headaches are a 3, and he decided to use some really colorful language describing his headaches. He called it annoying, blinding, boring, and pricking. Should be a writer. And we're going to do our assessment, and both of those are B's. And we're happy we hit done. If everything else is the same, I can simply hit done. I'm at the super bill. I hit the button here that says send to Funky. I hit done again. My note is now done. After you have the data in there one time, it gets extremely fast. The key is just getting the data in there the first time.
Let me ask you a question. That data that you put in there was through a VC note. Let's just take it in, and this is probably the count of future training to stop me, but you got a brand new patient. Will that data come over from their initial exam to the VC note, or you still have to go through that process if you just went through the 18 screens?
That's a very good question. Anytime you're doing a new patient, you want to go through the 18 screens. Now, if you're moving from stage to care, or you've done a new treatment plan, and we're kind of jumping the gun a little bit here, but each DC note is populated by the previous DC note. Patient problems and problem rankings come from new patient when you've done a case history. However, each DC note from that point on is populated strictly by each previous DC note, unless you have just done a treatment plan and not done a DC note since it. I know it's a complicated thing to think about here, but for example, let's say Superman's been coming in to see us a million times, and all of a sudden he comes in with low back pain. Well, we do a new exam and a treatment plan on him. It wouldn't make sense that all the therapies get geared towards doing it on the cervical musculature. So instead, it's going to come from whatever you chose on the treatment plan. However, if I do another DC note and I'm still doing after the treatment plan, and I'm still adding things such as interferential over the cervical musculature, it will say both. It takes a couple seconds to think about it, but it's that way for a reason. That way, it's always keeping up to date. And it's not. It's the treatment plan mainly just moves the modalities and those types of things over. And unfortunately, because of that, the treatment plan becomes like doing an entire new DC note. So you have to go, when you do a treatment plan, you have to do a whole bunch of information on it. But it's a very good question. Next, what we're going to do is we're going to go over the DC note again, and I'm going to, because at this point most people are kind of thinking, okay, I can kind of see how I can do this all by myself, but how do I get my staff involved? How do I do this? How do I make it so the burden's not entirely on me? How do I let the staff know that are doing the rehab, how many minutes to do and things like that? And the answer to that is the button called limbo. You can put patients in and out of limbo as many times as you want. And what it does is it doesn't finish the note, it leaves it in the visit summary and disappears, and somebody else from another computer or even the same computer can take them out of limbo and modify, change things, put them back in limbo, or finish the note. And you can go back in and out of limbo as many times as you want. So we're going to find our friend Superman. We're going to change the date to Sunday. I don't know if we did Saturday or not, but we're changing the date to Sunday anyways. And who knows why we're sitting here working on Sundays, but it is what it is. And we're going to hit select. Again, we're good with these things, so we're just going to ignore them for now. And we're going to hit, we see he has the diagnosis, he has problems, it's time for visit summary. And perhaps somebody in your office, whether it's you, whether it's the front desk, whether it's one of your CAs, whoever, sits there and asks some subjective things. How are you doing? And Superman says, I'm doing better. And my neck is now a 4, and my headaches are like a 1. They're almost not there, but I'm not ready to say they're completely gone. And then they put the patient in limbo. That patient is now in limbo and will remain in limbo until somebody takes it out. If somebody actually has a brain fart or something like that and goes to select them from outside of limbo, it will remind you. But ideally, hopefully people sit there and know that they look for patients from limbo. And you can see the things that were changed by the last user. Now what they do is maybe the next person, they're responsible for checking on the range of motion. And maybe on the range of motion, we're going to modify the cervical, and maybe it's only left rotation that's not restricted. Everything else looks pretty good. They're happy with it. They put the patient in limbo. Maybe somebody else in the office comes in, gets a patient from limbo, and their responsibility is to do the modalities and the therapeutic exercises. They look at the modalities, they see, okay, we do laser, and then we do attended stem. We did those things, no reason to change it. Progressive rehab, we're doing this, but you know what? He actually did them all for 15 minutes today. And we're happy with it. We're going to hit done. We hit done again. That's now changed. Put it in limbo. Maybe the doc is the last one to see it. Sometimes the doc's not the last one to see. Everybody, each office works a little bit differently. But in this scenario, we'll say the doc's the last one to come in. He gets the patient from limbo, and he makes his changes. Well, those are the segments I adjust usually. No reason to change it. I'm good. I hit done. I hit send to funky. I hit done again, and my note's done. So the total time spent for the doc is, what, 10 seconds? See what to adjust it, and hit done, done, or done, send to funky, done, and then exit and save. Maybe he wants to sign it to it. Wow, you with my phenomenal handwriting here again.
Regarding the signature, starting off without a tablet, how can I get the signature in there?
If you're starting off without a tablet, you could either try and use your mouse, but it's really hard. Instead, what I would do is just go to Edit Custom Text and create something that says digitally signed like this. So from the Easy Notes main screen, you would hit Edit Custom Text, and you can type whatever you want up here, and then whatever text is down there, and say digitally signed. And when you choose the words digitally signed, it says this treatment note was digitally signed. So you can just go to, and then maybe put in your name and things like that. It was just a quick example from the last person. But let's say Superman comes in, and it's now the next Monday. He's been spending a lot of time at our office. Oh no. Go to visit summary. Everything's exactly the same. We're done. Wherever you have the mouse, you hit Insert Custom Text. Right down here. You pick the one that you wanted, digitally signed, and select this text. Then it goes in there. This treatment note is digitally signed, and then put by your name.
Okay.
So that would be the best way to do it initially. All right. Now, normally at this point, everybody's head's spinning a little bit. So I want it to be the next thing we go over to be a little bit easy on you, and that's going to be X-ray report. X-ray report is very simple. There are only 3 screens, which is nice. You have what views you took, what was normal, what wasn't normal. Pretty simple. So we did an X-ray on Superman, and he's been coming in for neck pain. And we did an AP lower cervical, an AP open mouth, neutral lateral cervical. And there was no fractures. Bone density seemed normal. Maybe I didn't use enough KVP or too much or whatever. You can never remember if it's KVP or MA that you got to mess with. But soft tissue appears normal. Cervical structures are essentially normal. Has the same amount of bones as everybody else. Cervical disc spaces are good, except where I say they're not. AP is generally in good alignment. There's no luxations. There are some subluxations. I hit done. I move to cervical hypolordosis. Maybe it measures at 20 degrees even. I move to DJD. Maybe that's mild and it's lower cervical, C5, C6, C7, and T1 from all the crime fighting. So maybe I see some left spinous rotation, and I see it at C2, C3, C4. The nice thing about this is in case I have a brain fart, I can't say C2 and C3 and C4 are both left and right rotated. Things happen and we could accidentally hit buttons. So there's a lot of things in here constantly trying to help you. Here we go to disc thinning, and it was mild between C5, C6 and C6 or C7, T1. Excuse me.
Hypolordosis, are you required to put the degree of lordosis?
No, you could have hit. I could have hit the button that says "Do not measure."
Oh, I didn't see that.
Yeah, I'm sorry. This was supposed to be. This is supposed to, ideally in my mind, this is kind of like a mental breather while you're trying to absorb all the stuff about the DC note, because the DC note is the most important thing and the thing that ideally is what's you have to wrap your mind around first. But yes, I could have hit do not measure, but technically I think you probably should measure. But that option is there for you, and in case you ever forget how to do it. You basically just draw a line from the back of C1 anterior tubercle, C1 straight backwards, underneath C7, the vertebral body, anterior, inferior, and posterior inferior body of C7, and you draw parallel lines, you connect them, and you measure. But and I'll put something in here to remind you how to do all that fun stuff. All right. So next, and we already alluded to this a little bit, was the treatment plan. The treatment plan is not something you should be trying to do in real time like everything else I've shown you. The treatment plan is something you should actually, it requires a lot of thinking, or maybe not a lot, but a lot more thinking than the other things. It's not more reactionary, it's thinking about, okay, what are we going to do with this patient in this case? So we're going to find our friend Superman. And we're going to say he's symptomatic. Estimated number of visits are 12. Visit frequency is maybe 3 times a week for 4 weeks. Expiration date is always automatically 1 month from the day you create it. We're going to do some ADLs. Maybe we're going to teach him how to fly better, but we're not going to do any therapeutic activities. Perhaps we're going to do some interferential over his. Depending on, again, where I click here, I get a different list. But we're going to do some interferential over cervical musculature, and we're going to do it we're planning on doing for about 12 minutes at a time. Initially, we're going to be doing cryotherapy over cervical musculature for 12 minutes because we're going to lay them both on at the same time. At least that's the plan. Maybe we're going to do some laser in the same area too, and when we do it, we like to do it for 9 minutes, or however your office works. Okay, one of the things that's very important, let me move this thing over here again. One of the things that's very important for that you definitely want to make sure you're doing, and that is understanding manual therapy goals, exercise goals, and neuromuscular reeducation goals. Goals are very important to everything that we're doing. So perhaps in your office you use some myofascial release, and you do it over the cervical musculature. And you generally plan for about 4 to 5 minutes of it before he says, "Doc, you're killing me." And then you follow up with a little bit of trigger point therapy over the cervical and upper thoracics. And you can usually get away with that for maybe 3 before he says, all right, I get it. Alright, next what we're going to do is we're going to go to manual therapy goals, and it was to decrease trigger points, maybe increase mobilization, decrease adhesions and pain. Therapeutic exercises, we're going to do cervical phase 1, and because he's so strong, we're going to just start him off right at severe at 10. We've got our goals are to increase strength, flexibility, and endurance. Neuromuscular reeducation, we're going to maybe do a little bit of PNF, and that's to improve proprioception. And let me move this thing down here. Whoop, and kinetics. Put it back up. Alright, now we're at the adjustment techniques. We do diversified, and maybe we'll use a little bit of drop. Short-term goals, we're going to increase the cervical range of motion, maybe by 10%. We're going to decrease the discomfort, though, by 85%. We expect that to be about when it's time for him to sit there and say, well, you know, do you really think I need to keep coming in here? I'm feeling so great. Long-term goals, maybe drive with no pain. Let me move this thing down here so you can see the other buttons. I'm going to hit an other here, and I'm just going to enter in fly with no pain. And we're going to put perhaps another one, fight crying. And again, I could have used handwriting recognition. Next, we're moving on to complicating factors, and perhaps it's age. Who knows how old he is? You know, he's Superman. Could be a million. Maybe he has some compromised nutrition. Maybe he's had the pain over 7 days. One of the things that Dr. Hoban had me put in here that I just think is absolutely genius, and that is to actually say up front what the medical necessity is. That way there's no prove to me medical necessity. You know, you're the doctor, you get to sit there and say what the medical necessity is, and as long as you say it, it is what it is. And without treatment, the issue will remain, and it's expected to reduce symptoms and improve function. When we're happy, we hit done, and we have a nice treatment plan. We can sign on screen, or we can use what you alluded to before, which is the insert custom text, digitally signed. Boom, it's in there. We hit exit and save. Alright, our next thing is to do exams. And if you don't mind, I'm just going to pause just for a second. My voice is starting to burn for a second, so if you just give me 2 minutes to go and grab something to drink for a second, okay? So our next thing to go over is the exam itself. So we're going to hit exam, and we're going to find our friend Superman. Now exam is a lot like the DC note. Everything gets populated based upon the last exam, or a lot of things do, not everything. Height, you know, in feet and inches do. Blood pressure does not, either does weight. One of the things I've found is it's amazing, you know, how much a person can gain from walking from a consultation when they tell me they weigh 120 and I put her on the scale and she's at like 160. I don't know how it happens, but it does. So Superman's probably about 6'2". Blood pressure is probably absolutely amazing, maybe 110 over 75. And he's probably about 220. Maybe we notice he's got it. His shoulder's normal. Maybe he has a left head tilt. Iliac crest is normal. Normal head carriage, as far as we can tell. Now we saw, you know, there was a decrease in lordosis in the cervical spine in the X-ray, but an exam looks normal to me. And we check his arches, and his arches are fine. We're not going to deal with lumbar ranges of motion or thoracic. We're just going to go straight down here to cervical. Let me move this thing over here again so you can see the entire screen. And what I like to do is, if I know, you know, you usually have an idea of where somebody's at. If everything's going to be basically normal and you change the few things that aren't, or if everything's going to be limited and you change the few things that aren't. So we're going to say everything is normal. So I hit up here where it says everything is normal. Let me show the mouse so you can see it. Or I could hit limited all, or within normal limits all. And I'm going to make everything normal except lateral flexion and left rotation. Left lateral flexion and left rotation are limited. left rotation created pain. It was moderate in his, and I'm going to go to these figures here, in his right cervical musculature. And it was at 60 degrees. And this one's just limited, I'm not saying how many degrees. Maybe the dual inclinometer slipped or something. Now I move to the orthopedic tests. What I can do at any time, I can hit show in case I forget exactly what some of these things are. Or if I remember them really well, and I know this is positive on the left, and it was the C6 dermatome. Maybe cervical compression with rotation was normal. Valsalva was normal. We're just doing cervical, so we can ignore those. Maybe those are the only tests we did. Maybe what is Soto Hall? Soto Hall was normal. Maybe I added one in here. We're looking for the rust sign, and it was normal. And when I'm happy, I hit screen 2. Now I move to screen 2. What it does is it remembers the subluxations. Oops. It remembers the subluxations that I've been adjusting, and automatically fills those in for me. Of course, I'm still the doctor, and I can overrule them. And perhaps what we have is we've got the levator scapula on the left is a 2. On the right, it was a 1. The rhomboids were a 1 bilaterally. Maybe the supraspinatus was a 1 bilaterally. Maybe the infraspinatus was just a 1 on the left. And traps were a 2 on the left and nothing on the right.
Quick question there.
Yes.
I'm using another EHF system. I know what you're doing right there for the muscle palpation is based on health source.
Exactly.
1, 2, 3 is mild, moderate, severe, I guess.
Correct. Mild, moderate, and severe. So.
Trigger points.
It's basically for trigger points with referral to them. So it could be anything from pain for the patient to what you're feeling.
Yeah. Okay.
That's my understanding about it. Now we move to neuro exam tests, and we're going to say all upper normal. Maybe all, and now I move to reflexes, and I say all upper normal, except for whatever reason, L or C5 on the left was 3. When I'm happy, I hit this button here that says finish. Now it asks me if I'm treating today. Yes, I'm treating today. Although at this point, if you're not, if you like most health source doctors, you don't treat on the first day, you would say no, and then you go to the super bill. But at this point, hopefully, you're feeling somewhat comfortable with the super bill and no reason to do it. And we end up with our note. Put this down here. And we can sign, or we could insert our custom text or whatever we want to do. Now, the important thing is to see what happens the next time you do an exam on it. So perhaps, let's move this taskbar over here. Again, sorry about this, but need to figure out a way to make it so that for the people can see that haven't had a chance. And we go down to the bottom, and we change the date to a month from now. And we hit continue. Now everything is filled in for me except for the weight. Obviously, what have I done here? Move this thing down. Try it one more time. There we go. Oh, I put it on top. That's better up there. Anyways, so we go to the weight, and on the weight, that's something that fluctuates. For adults, except for adolescents and really old people, someone that's 6'2" stays 6'2" for years. And we're going to say, he's still, maybe he had a couple extra Twinkies, now he's 225. I only now need to change what's different. Of course, I should still test everything, but what's different? Maybe now his head tilt is normal. Maybe his left lateral cervical flexion is now normal. He still has decreased left rotation in the cervical spine, but there's no more pain. And instead of 60, it's now up to 70. Maybe cervical lateral compression has become normal. I'm happy with everything. Instead of, we're going to hit cancel there. Maybe we didn't do the rust sign again. We're happy. We hit screen 2. These things are filled in for me again. Maybe the rhomboids are now a 1. This one's non-existent. This one's now a 1. These are non-existent. And this became a 1. So he's down to just about everything. And maybe now his C5 reflex is normal. When we're happy, we hit the button that says finished. Are we treating today? Yes, so otherwise we'd go to the super bill. And now our note's done. So it gets extremely fast. Now obviously today we went over the DC note, X-ray report, treatment plan, and exam, and there is a whole bunch of other stuff to do, but it's very important to not try to tackle too much at once, otherwise things start getting jumbled up together. So let me just stop the recording right here, and then I'll open it up for any questions you have.
Back at that exam,